Good evening, everyone, and thank you for joining us tonight. It's my pleasure to welcome you, our closest friends and supporters, to this virtual edition of our speakers series with Dr. Paul Offit and Dr. Jayatri Das. Before we begin, I want to take a moment and not only thank you for your support, but also give you an update on a couple of things happening at the Franklin Institute. First of all, a couple of weeks ago, we opened a new exhibition, Crayola IdeaWorks, the creativity exhibit. I hope you and your family come and enjoy this great exhibition that really talks about creativity. It helps talk about and shape some of the skills necessary, not only in science, but in our everyday lives, like creative decision-making, problem solving, and critical thinking. It's a fun, colorful exhibition, and we hope you come and join us for this exhibition, which lasts through the middle of the summer. And then, as some of you may have seen in local media recently, just last week, the Institute was proud to announce that we will be the world premiere location for Disney's 100th anniversary exhibition in 2023. We look forward to sharing more details with you about this exhibition, but look forward to being the center of Disney in 2023. And finally, our annual Franklin Institute Awards program is happening virtually on April 29th. We're very excited to honor the 2020 laureates, who are now our 2021 laureates, and their amazing scientific achievements. We're also thrilled to share with you early news, and that is that it'll be announced to the public in the next few days. The winner of our inaugural Next Generation Award is Dr. Kazumiki Corbett. Dr. Corbett is a viral immunologist at the National Institutes of Health Vaccine Research Center, and she was pivotal in developing Moderna's groundbreaking mRNA vaccine. It is thrilling to be able to honor her and the work she is doing, saving lives every day. More about Dr. Corbett in the future, and Dr. Corbett will also participate in April in a program with Dr. Das as well. Very excited about that. More information to come to you. But tonight, we're grateful to be joined once again by Dr. Paul Offit, a member of the Institute's Board of Trustees, Director of the Vaccine Education Center at Children's Hospital of Philadelphia, and a member of the FDA's Vaccine Advisory Committee. Together with our host, Dr. Jayatri Das, the Franklin Institute's Chief Bioscientist, we'll learn more about the recent COVID-19 vaccine developments and what it means for paving our way out of this pandemic. Again, on behalf of the trustees, the staff, and everyone we serve at the Franklin Institute, thank you for your critical support. You helped us get through this very tough year, and we look forward to welcoming you back in person to the Franklin Institute soon. Dr. Das.
Thanks, Larry. And I'll echo Larry's thanks to all of you for helping us through this year and for your dedication to science. I think this year has really shown us how important science is in ways that have become more obvious and affected each of us. And that's something that's going to continue, maybe not quite so obviously, hopefully, in terms of our personal health and well-being, but in all the ways that make our lives in this modern world. So thank you for that support. Paul, you joined us back in the fall, and as I was preparing for tonight's event, I was thinking back to the fact that where we were at that last conversation is a very different place in the pandemic from where we are today. Back in the fall, we were hopeful that there might be some vaccines around the corner, but we also knew that the winter holidays were coming and that was likely to lead to a surge in cases. Where we are now, I think there's a lot more hope to be talking about, and I'm excited to get into that. And so we've got a lot of questions that came through from our attendees tonight that we'll get to, but I do want to encourage everybody who's on tonight, if you have more questions that come up, please go ahead and put them in the Q&A box. You'll find that option to put your questions in. If you have thoughts to share with the group, we welcome some of your reflections on your experiences throughout the pandemic. Go ahead and share those in the chat. But we'll be looking at that Q&A section for specific questions that, that Paul can give us some answers on. So I wanted to start actually with, again, on this note of hope and optimism, because I think The CDC's announcement yesterday about some preliminary guidelines of what we can do after we've been vaccinated was something that everybody was waiting for. And if you haven't read the news, the kind of the top level details are that if you've been vaccinated, you can go ahead and start, having some small gatherings with other people who have been vaccinated. If you've been vaccinated, you can have small gatherings with a single household of people who are not yet vaccinated, but at low risk. But we still have travel restrictions in place. So that gives us some roadmap on how we can start to emerge from the isolation that we've been in. So Paul, I thought we could start by asking you to help us understand kind of what the data that the CDC has been looking at that is helping us come to those guidelines in terms of life after vaccines.
So I think they see the light at the end of the tunnel. We're still in the tunnel, but I think they see the light at the end of the tunnel in that there clearly has been a pretty consistent decrease in cases, hospitalizations, and deaths. That's number one. Number two is, although they list that roughly 29 million people in the United States has been infected, that number's low. Those are just people who've been tested and found to be infected. When they do antibody surveillance data, meaning just take large numbers of people, screen to see whether they have antibodies against the virus, that tells you how many people have really been exposed. And that 29 million number is off by a factor of at least 3. It's probably closer to 85 million people who've already been infected with this virus. It's just 25% of the population. That's not trivial. I mean, that 25% is likely to be protected against moderate to severe disease when exposed to this virus. So you can consider them as being vaccinated. So it's 25% have been vaccinated. Another 10% have been fully vaccinated. So now you're up to 35%. And another 10% have started to be vaccinated, gotten their first dose, which offers some immunity. So that's not bad. I mean, you're getting there. And, we're giving 2 to 3 million doses of vaccine a day, and the weather's getting warmer. All of that works against the virus. We aren't there yet, though. So you have to be careful. I mean, today there were 50,000 cases and 1,500 deaths. Those 50,000 cases, again, are only people who were tested and found to be positive. Assume it's 150,000. That's probably right. The 1,500 deaths, although we're sort of getting numb to this, is a lot of people dying. I mean, remember polio. I remember polio. I was a child of the 50s. 1,500 children died a year of polio. Here you have 1,500 people dying a day of this virus. That's not trivial. So you still have to be careful. We're still in the midst of a pandemic. I guess here's how I look at this. This is going to sound counterintuitive, but what the heck. There was a study done in Europe a number of years ago looking at a measles outbreak. And they tried to answer the question, who was most likely to get measles during this outbreak? Measles, like this virus, is highly contagious, although measles is actually even more contagious than this virus. But what they found was, not surprisingly, you were very unlikely to get the virus, to be infected with measles, if you were vaccinated, living in a highly vaccinated population. So you're vaccinated and you're surrounded by people who are vaccinated, therefore sort of a moat around you. You were more likely to get infected if you were vaccinated, living in a highly unvaccinated population, than if you were unvaccinated, living in a highly vaccinated population. Why? Because even though you're vaccinated, if you're living in a highly unvaccinated population, you're more likely to be exposed to the virus, and no vaccine is 100% effective. I think you can consider yourself in this population now, if you're vaccinated, as living in a highly unvaccinated population. So you're still at risk. And so you still need to be careful, I think. No vaccine is 100% effective. I mean, just personally, I'm fully vaccinated. I've been fully vaccinated for like over a month. But when I go outside or go into where I know there's going to be other people, I wear a mask. I'm still, careful, because I may be that 1 in 20 who, despite being vaccinated, could become ill. So I think we are so close. I think if we can just hang in there for the next 2 months, I think we can get to where we want to be. We can get to the promised land. We have to get to about 80% population immunity, I think, to get to the promised land.
So Paul, that answers a question that a couple folks had asked, is what is the threshold that we need to reach to get to this idea of herd immunity, where there's sort of enough people vaccinated or immune from prior infection that we reach that place where we're kind of protecting each other. And so what's the trajectory we should be looking at in terms of being confident that we reached? Are we looking at the number of cases to level off? How do we tell?
It's going to be hard to tell initially because summer's coming, and in summer the virus is going to spread. The virus spread last summer, but not nearly as much. I mean, the virus came in and started to kill people at the beginning of March last year. So we were starting to enter, sort of late winter, early spring, and you started, came in. And then you started to sort of see it eventually come down. It sort of, and we were fooled by that. We thought, great, we're getting in control of this. All the masking and social distancing we're doing is getting control. People wanted to go back, and there were states that sort of sent people back. And we did the experiment where you show that if you do that, you actually have a problem. So the tell-all, the test will be next winter. If we can get to 80% population immunity, which means that if we have roughly 40% of people immune now, we're going to need to vaccinate another 120 million people. That's since most of the vaccine out there are 2-dose vaccines, that's 240 million doses. If we can give 2 to 3 million doses a day, we can get there by the summer. 80%. Now what's going to happen, I predict, is that's when you're going to start to see who doesn't want this vaccine. Right now, the people who want it can't get it. So so once we have enough vaccine out there, you're going to see there's not a trivial percentage of the population that doesn't want to get vaccinated. That's going to be a problem. But if you can get to 80%, then you'll see, then I think when next winter comes, you'll see just a bump of cases. Whereas if we don't get to 80%, you're going to see a surge of cases next winter. This is a winter virus, and it's not going away. It's not going to go away for a long time. And here's what I mean by that. To go back to the polio analogy, we still vaccinate children in this country with polio vaccine every year. Why? We haven't had polio in this country since the 1970s. The reason that we do that is polio still exists in the world. It's in Pakistan, it's in Afghanistan, international travel is common. You are only as strong as your weakest countries out there. And keep in mind that 194 countries exist, 130 of them haven't given a single dose of vaccine. So this virus is going to be around for a while. We're going to be immunizing people for a while until it's not just in control here, but in the world.
That's a really good reminder that, as we look at the trajectory, we can't just look at our own county, our own state, not even our own country. One question that's come up is the role that children play in spreading the disease. Do you think we can get to that level of immunity that we need to get before we start vaccinating children?
I think we can get there by vaccinating older children. So right now there are studies that are ongoing looking at the 12 to 18-year-old. Remember, the people less than 21 account for about 26% of the population. So I do think we're going to have to vaccinate some children. The 12 to 18-year-old studies are ongoing. I think really by the summer, we will have vaccine for those children. And then the studies, we're going to go, after those studies are done, or while those studies are being done, we're going to look at 6 to 12-year-old children and study them. And then I can imagine that by the end of the year, we would be able to vaccinate them. I don't think we're going to be aiming for children less than 6 years of age, actually. And I think we can get close to population immunity without vaccinating, obviously, all children, just the older children, I think, initially.
Okay, so we have a ton of questions about the vaccines themselves. And so let's dig into those. So the first question that I want to throw to you, Paul, is how do the vaccines work in our bodies? What do we know about how long that immunity might last after vaccination?
Right. You're recording this, right? Oh, you are recording. Okay. Well,
we are recording this
anyway.
But we won't hold you to it if there's things that we just don't know yet.
Yeah, that's what you're saying now. I think that I am encouraged by the fact that with the second dose of mRNA vaccine, Pfizer or Moderna, or with a single dose of the Johnson & Johnson vaccine, you induce not only antibodies, but also so-called cellular immunity. So the cells have names like T helper cells, which are the kind of cells that help B cells make antibodies, and then a different subset of T cells called cytotoxic T cells, which actually kill virus-infected cells. When you see that, that presages a longer duration of immunity. So I'm going to predict that immunity would last 2-3 years. I don't think it'll be decades, but I think it will be for a few years. I don't think we're going to have to need a booster dose every year in the manner that we give a flu vaccine every year, because though this virus also creates variants, it's not nearly what flu is. I mean, flu is a moving target. We give a yearly vaccine because natural infection or immunization the previous year doesn't protect you the following year. I don't think that's going to be true here. I think that it will be that your vaccination will be protected for a couple years, 3 years. The reason that we may end up giving a booster dose would be if one of the variants resists all sort of immunity induced by natural infection or immunization, and we're not there yet.
Right, right. And you were just saying that, you're on the panel that predicts which variants of the flu, you'll design a vaccine on every year. So that's not something that you're seeing happening right now.
Well, we actually met on March the 5th. The FDA Vaccine Advisory Committee met on March 5th to pick next year's flu strains because it's a 6-month production cycle. We pick the strains in March. The vaccine then rolls off the shelf in September. So, and we base that on sort of what flu strains are circulating throughout the world. So usually there are certain countries like Australia or South America whose flu seasons precede ours. So you can sort of get a sense of what's going on. This year, flu is gone. It is amazing. I mean, everywhere, Australia, South America, this country, so, it's just has had virtually no flu. And not just no flu, other winter respiratory viruses, like viruses that have names like respiratory syncytial virus or the human coronaviruses, or parainfluenza virus are just gone. It's like maybe we were really good at picking flu strains last year, but I don't think that was it. I think it has something to do with the pandemic. And so it's like, obviously we can't duplicate that because there were many mitigation strategies, not just masking and social distancing.
Sure.
We closed schools, businesses were closed, travel was restricted or limited, and we're not going to do that. You wonder whether some small part of that may be of value, because 3 years ago 60,000 people died of flu. The year before that it was 20,000, or after that was 20,000. So these are bad viruses too. It's just somehow they've gotten grandfathered in.
So when we're thinking now that we have 3 vaccines available to us, a lot of folks are asking, is one vaccine better than another? Are there different risks and benefits to each of the vaccines when it comes to efficacy or side effects?
Yeah, right now, just as a general point of advice, get whatever vaccine you can. Don't wait for a particular vaccine to become available because the virus is still raging in this country. 50,000 cases a day, it's probably 150,000, another 1,500 deaths daily. Here's what I would say. If you look at the data, and again, I want to emphasize these are data from studies, and the studies are done very carefully, and everybody makes sure that they maintain the vaccine at the right temperature and are giving it the right way. They don't violate any protocols. In the real world, things get a little sloppier, so it's not quite the same. It's the difference between an efficacy study, which is what's done by the companies when they study it before licensure, in this case approval, and then effectiveness studies where you see how it really plays out in the real world. So, but what you can learn from the efficacy data is that the 2 mRNA vaccines are both roughly 95% effective at preventing all manner of disease, mild, moderate, severe disease. And they're very effective in people over 65. And it's very effective across all comorbidities, meaning the various medical problems. And it's effective for all racial and ethnic backgrounds. It's amazing. I mean, really, the data are great. And it's obviously 100% effective against very severe disease, meaning hospital, ICU, death. Johnson & Johnson's vaccine, which is made differently than the mRNA vaccines, is not quite as effective against all manner of disease. It's about 72% effective in US. I'm just talking about US data because they studied it in many other countries. 72% effective in the US against all manner of disease, 85% effective against severe disease, meaning the kind of disease that would cause you to seek medical attention, and 100% effective against hospitalization and death. The advantages of that vaccine are it's a single dose, and it does induce cellular immunity after a single dose. So, you don't have to wait to have what is likely to be some reasonable duration of immunity. It's refrigerator stable. It's refrigerator stable for 3 months, which makes it much easier and much more foolproof out in the real world than, say, a Pfizer vaccine, which has a 5-day life in the refrigerator. It's been tested in South Africa, where the South African variant, not surprisingly, is common, amounting to more than 90% of the strains that are circulating, and was found to be 100% effective against hospitalization and death. It was tested in Brazil, where 70% of the strains that are circulating in Brazil are the Brazilian variant. And there it was found to be, also 100% effective at preventing hospitalizations. There weren't deaths in that Brazilian study. That's good. Now, I suspect the mRNA vaccines are also pretty much equally good at preventing disease associated with those variants. We don't know that because we haven't done those studies. So those are the advantages of Johnson & Johnson's vaccine. Now, that said, Johnson & Johnson is currently doing a 2-dose trial to see whether the second dose is even better in terms of the immunity. from great to even greater. And we'll probably know that in the second half of this year.
So my sister's actually in that 2-dose trial, so she'll be one of the numbers that we're looking at. So another question that's come up is whether there's any advantage at a point where we get to more widespread availability of the vaccines to get multiple vaccines. Like, should you go and get the J&J after you've already gotten the Moderna? Is there any benefit to that?
No, I wouldn't do anything that hasn't been studied. So you have abundant data on 2 doses of the mRNA vaccines, whether either Pfizer or Moderna. You now have abundant data on Johnson & Johnson vaccines. You also now have the mRNA vaccines have been in tens of millions of people. So you can say that it doesn't even have, at this point, a rare serious side effect. J&J will see, I mean, as that vaccine rolls out there, and when it's in millions of people, we'll be able to say the same thing. No, I don't think you get to sort of make it up as you go along. You should stick to the science.
Yeah, no, that makes a lot of sense. And you mentioned side effects. How is it being handled for people who have known risk of allergies?
Right. So all vaccines can cause an immediate type allergic reaction called anaphylaxis, which is pretty scary to watch. I mean, your blood pressure can drop, you get sort of tingling, you feel faint, tingling in your arms and legs, and you feel faint. The good news about it is that it happens immediately, usually within 15 minutes of getting a dose, and it is treatable with a single shot of epinephrine. So that's why you wait around. It's true for all vaccines. For all vaccines, you should wait at the site where you got that vaccine for 15 minutes. For people who have, now for the Moderna vaccine, the estimate is that 2.5 per million doses is complicated by that side effect. For the Pfizer vaccine right now, it's 5 per million, but those numbers will probably even out over time, and will probably lower over time, actually, as we get more and more doses out there. If you've had a severe allergic reaction to a food or to a medicine, you can still get the vaccine. You just have to wait for 30 minutes after you've gotten the vaccine, and all other people 15 minutes.
One of the questions that was kind of outstanding in terms of figuring out what type of guidance to give people is a question about whether you're still transmitting the virus after getting a vaccination. What kind of research is being done right now to understand more about that question?
Right. Not an easy question to get at, and I'll explain why. So in the Johnson & Johnson trial, they actually looked at that. They looked to see whether or not people didn't have symptoms, so they would, periodically test do a, nasopharyngeal swab to see whether or not they had evidence of this virus's genome, the so-called PCR test. And they found that that those who got the vaccine were about 68 or so % less likely to have asymptomatic infection, meaning you don't have any symptoms, but you're still shedding the virus. But does that mean they're contagious? Because that doesn't tell you that. I mean, just getting a swab and seeing that you have a viral genome there doesn't tell you whether or not you're contagious. Even if you did the kind of test where you could see whether there was viral protein there, which is a little closer to the whole virus than just the genome, that doesn't tell you. The only way to really know that is to do something called contact tracing, which is vaccinate people, don't vaccinate people, see who's asymptomatically infected and shedding, and then see whether they get out there in the real world and they come in contact with people who are not immune, whether they're more likely to infect them. Those studies will never be done. So we're never really going to know this, just to lower expectations. I'm not sure it matters that much, even though we talk about it all the time. There are a number of vaccines which are not great at preventing asymptomatic infection. Rotavirus is one example, whooping cough is another, influenza is another is the conjugate pneumococcal vaccine. Nonetheless, we've been able to get on top of those viral or bacterial infections with vaccination. I mean, rotavirus, which was a common cause of disease and hospitalization and less likely death in this country, we've dramatically reduced the incidence of that. Many of the residents in our hospital don't even see that disease anymore. It's a cause of fever, vomiting, diarrhea in young babies. And that doesn't prevent, still children can shed. I think what we'll learn, here's what we're gonna learn. We're gonna learn that we're gonna learn that people who got vaccinated may still shed virus, but they would shed less virus than those who weren't vaccinated. I think that's what we're going to find. We make a lot of this, but I don't think it's going to actually be that critical, really.
It's just easier just to vaccinate more people than it is to try and figure out how many other people a vaccinated person might possibly infect.
Right.
It's kind of a hypothetical there. In terms of practicality, We know that as for the 2-dose vaccines, there are recommended intervals between the two doses. What do we know so far about potentially the effectiveness of a single dose, or what happens if you wait longer to get the second dose?
Right. If people get nothing else from this talk, get this. The mRNA vaccines are 2-dose vaccines. They are. Now, the CDC has tried to account for the fact that there was not enough vaccine initially. So even though in theory that you should get the Pfizer second dose 3 weeks after your first dose and the Moderna 4 weeks later, they said you can get both up to 6 weeks later. Fair enough. I don't think that's a big deal. But those sort of that cellular immunity I was talking about, which sort of predicts a likely durability, does not happen after 1 dose. It doesn't. And you have a lower immune response by a factor of 10. Although there is some immunity, no doubt, by that with that first dose, I think it is going to be short-lived and incomplete. And Dr. Fauci has made this very clear, and as have a number of people, but there are people on national television who occasionally will say that it's okay to get 1 dose. That's not true. It's a 2-dose vaccine. So get that second dose. How long you can wait, I guess we're going to find that out retrospectively, but certainly get it as soon as you can, as soon as at least 3 or 4 weeks later, but as soon as you can.
That's really important. Thank you for clarifying that, because certainly there are other countries as well that have considered really prioritizing getting that first dose out and maybe not prioritizing that second dose, but get both doses. So a couple more questions here around the specific aspects of the vaccine. If you've had COVID, is there any danger in getting the vaccine before you've been clear for 90 days?
No, I think that the current recommendation, if you have COVID, if you have the disease, you can get the vaccine when you have no more symptoms. But the truth is, and the CDC has not weighed in on this, the truth is, if you've been infected with this virus, you're immune. I mean, when in the world of vaccines, well, certainly we were making our rotavirus vaccine, the critical question that you need to answer before you ever begin to make a vaccine is, does natural infection protect you against disease associated with re-exposure? Because if it doesn't, you're in trouble. If natural infection can't induce immunity that's protective, you're in trouble. So we kept waiting when this virus came into this country. Are there people who've been infected and survived that then get reinfected to the level that they have to go to the hospital? Because that tells you then that natural infection doesn't protect. I know that everybody thinks that natural infection always protects against disease, but it doesn't. I mean, strep throat is a perfect example. You can get strep throat again and again and again, and it doesn't matter how many times you have it, you're no more protected the next time you get it. That's one of the reasons that you don't have a strep throat vaccine. Same thing with gonorrhea. You can get it again and again and again. You're never protected the next time. So that's key. And that happened here. So you could reasonably make the argument that people who have been naturally infected and survived probably don't need a vaccine. Also, there's studies done now, there's been 3 studies just in the last week, showing that people who've been naturally infected that then get their first dose of mRNA-containing vaccine act immunologically as if they've gotten their second dose. So if you're trying to save vaccine, you could reasonably make the argument, the CDC could have, that if you've been naturally infected, you can get 1 dose. So the reason that we didn't make this distinction was really programmatic. It would have been really difficult, I think, to say, okay, we're not going to vaccinate people who've been naturally infected. So now everybody's going to want to see whether they've been naturally infected first, which adds another layer of testing before you get the vaccine. I think the CDC just didn't want to go there. They said, okay, let's just vaccinate everybody.
Right. I think we've certainly learned a lot about the complexity of messaging and communication throughout this, and we'll get to some questions about the systems in place to handle this. So yeah, I think that seems right. Is there a correlation with the severity of your COVID symptoms with the strength of your immunity? Do we know anything about that at this point?
Not necessarily. I do think one thing where people get confused is there were studies done showing that, and they certainly got national attention, that antibody responses faded. That you were infected, you had high levels of virus-specific neutralizing antibodies, and then it faded. But then there were studies done by a guy named Shane Crotty at UCal San Diego who showed that that's okay, that you still have immunological memory. And for a disease like this, that's good enough. And I'll tell you why. There's something called the incubation period of a viral infection, which is the time from when you're first exposed to the virus to when you develop symptoms. The incubation period for this virus is about 6 days. So you're exposed to the virus and then you get symptoms 6 days later. That's plenty of time for activation and differentiation of your memory cells to become like antibody making cells. So that's what you want to see. Some diseases have really short incubation periods, rotavirus being one, influenza being another. You can be you can be exposed to influenza and be sick 18 hours later. So even if you have immunological memory, it's really not enough to stop the virus as much as it is to sort of modify because it comes in later. So again, I think it doesn't matter whether you really still have antibodies. If you've been naturally infected, the odds are, independent of your degree of symptoms, that you're probably protected.
And one last question about the side effects here. Are the side effects, most commonly we hear about sort of that immediate, 1 to 2 days right after you get the shot. Is it common to have more long-lasting side effects from the vaccine?
No, I mean, the studies have been done showed, I mean, it's not an easy side effect profile. I mean, the 2 mRNA vaccines and the Johnson & Johnson vaccines, for different reasons, have, where you can, as many as 50% of people can get fever, typically low-grade fever, fatigue, headache, joint pain, muscle pain, diarrhea. It's not easy. It lasts 2 days. I mean, after my second dose, it tends to be higher after the second dose, but more symptoms after the second dose, and more symptoms in people who are younger than 65. But I certainly, after my second dose, had 2 days of fever, chills, fatigue. I mean, it wasn't easy, but what I found that worked, and I'm passing this on to all your listeners: whining for 2 straight days, and it was gone. So
you heard it here first, folks. Whine away. All right, just to switch gears a little bit, because we've been focusing on vaccines so much, all the conversation about different treatments of coronavirus have sort of, taken a back seat. Where are we with some of the different treatments that were being talked about in the fall, whether it's some of the monoclonal antibody cocktails or remdesivir? Where do we stand on those?
Right, so we have a long history with giving antibodies to people. I mean, back from the days of diphtheria anisera, which is what won the first Nobel Prize, tetanus-specific anisera. Anisera has a long, rich history, but it's in the treatment and prevention of infectious diseases. There are 2 facts to take away from that. One, they have to be high titered, meaning in this case, have high quantities of antibodies directed against that surface protein of the virus, that spike protein, which is what attaches the virus to cells. 2, it has to be given early in infection. This is true for all infectious diseases, early and high titered. The problem with those convalescent sera studies, for example, is they often were done in hospitalized patients when it's too late. So you really couldn't find that it really worked at all. It's the same thing with monoclonal antibodies. Those are just sort of more specific because it's directed against one particular immunological component. And again, early, because they're going to be high titer. That you got that with the monoclonal antibodies, but it has to be given early. A lot of the other fact that the antivirals have been largely disappointing for the same reason. That also has to be given early. So remdesivir, lopinavir, I mean, those sort of antiviral agents have been largely disappointing. Dexamethasone, the steroid, has been of value for people who have a certain critical level of lung disease. That's been of value. And then there's certain biologicals that are of value for people who have also this kind of so-called cytokine storm. That's been of value. But it's remarkable. There was a New England Journal of Medicine paper that was published actually not that long ago. I have it sitting right here in February 11th of this year. And it goes through sort of the antiviral drugs and as well as a variety of other drugs to see what works. A lot of things didn't work, is what we found. So that's why, as is always true, as Ben Franklin said, an ounce of prevention is worth a pound of cure. Larry made me say that.
And there's never too much Ben, as we were discussing. So one thing just to clarify here, because you mentioned the incubation and the level of virus that's present in the body. We've got a question about when is somebody most contagious versus when do they become symptomatic? And that's been one of the, it's one of the counterintuitive things about this virus. Can you talk about that progression a little bit?
Well, it's true of all viruses. You're actually your most contagious right before you develop symptoms. I mean, that's when you develop symptoms, that means that's your immune response responding to the virus. That's your so-called T cells killing virus infected cells. That's your antibodies trying to neutralize the virus. You are your most contagious right before that, day or two before you develop symptoms. That's what makes the viruses so heinous. I mean, people don't know they're contagious and because they haven't gotten sick yet. And then people think to stay away from people that are sick, which makes sense. But actually what happens is the virus sort of load goes up and up and up. Then the symptoms start. When the symptoms start, the virus load starts to go down. It's hard to avoid viruses like that.
Again, why vaccines are such a useful tool in this. Okay, so let's switch gears a little bit and start thinking about, life as vaccines start being distributed and where we go from here. I think I share a lot of people's frustration in terms of the distribution system, especially, here in Pennsylvania. I've been up at 11:45 every night trying to get a vaccine for my parents, using all of my skills gained in trying to get concert tickets to find an appointment at Rite Aid. So I'm sure that I'm not the only one who is dealing with that frustration. So maybe you can give us some insight into how this decentralized system has, seems to be the way that the states are disseminating this. Why is it, how did this approach come to be?
I'm not sure I'm the best person to answer that question. I can say this: we were really good at the vaccine part. It is remarkable, actually, that the previous administration was able to, within 11 months, create 2 vaccines that were this effective and this safe. We're going to look back at this moment as an historic moment. We weren't so good at the vaccination part, meaning getting the vaccine out there. Not so easy, because we don't have a public health system that was geared toward mass vaccination of adults. I mean, that's the main reason. And so we are getting better. I mean, you look at when the vaccine first came out, when it first rolled off the shelves, about 20% of the vaccine that was distributed was administered. Now it's as high as 70% because we're getting better. And there are mass vaccination clinics that are just waiting for the vaccine. How you do that, it depends on the sort of the states and localities and who you're going to vaccinate. The CDC, when they came up there with their guidelines, 1A, 1B, 1C, who you're going to vaccinate, it was a guideline. And I think some people sort of interpreted that as a rule that you had to finish 1A before you went to 1B or go to 1C. And the CDC really didn't mean that. They just were trying to come up with a guideline. So different states do it differently in terms of who they vaccinate and how.
Yeah, and just a couple of follow-up questions that folks have put in the chat here, just to clarify. So if you've had the Pfizer vaccine first dose and you get an appointment for a dose of Moderna, you shouldn't mix and match, right?
Well, the CDC actually has been lenient on with regard to that in the same way that they were lenient with regard to allowing a second dose up to 6 weeks later. If in what they call extreme circumstances, if you got, say, a Moderna vaccine, there is no way you're going to be able to get a second dose of Moderna vaccine in the near future. It is reasonable to get that. Now, we didn't study that. We don't know. And they aren't, although they're both mRNA vaccines, they are different molecules. I mean, one is given at a dose of 30 micrograms, the other at 100 micrograms, so they aren't the same molecule. But I don't think that's a leap. I mean, I think it's probably reasonable to conclude that you would still have a booster response, and those data are being generated. But the CDC was actually surprisingly lenient on that.
Okay, so I hadn't heard that. That's good to know. But in general, if unless you have any difficulty in getting the second dose, then you should stick to the same vaccine there. And then what happens if you have asymptomatic COVID when you get the vaccine? Does that interfere with the getting immunity with the vaccine versus fighting the disease?
So, I mean, I think I don't think so. Certainly that's, if you're asymptomatic, the CDC's recommendation is you can get a vaccine. So I don't think that will be a problem. Okay.
But that's all very useful advice. In your opinion, as we look at now as the vaccine is being rolled out, how confident do you feel in the Biden administration's projections that we'll get to this point in May where the vaccine is just widely available?
I think we're getting there. I mean, another 600 million doses was available today, I think. So I'm optimistic. But the thing that I'm worried about is that we'll have enough vaccine and that we would have enough vaccine to get 80% of population immunity, both natural infection and vaccination, and that a critical percentage of people will choose not to vaccinate. I mean, there is not a hospital in this country that has healthcare workers that are choosing not to vaccinate. I mean, all of us do. And so, and these are healthcare workers. So I do worry about the general population. It's interesting when they do studies. I was just called from somebody from Politico today. There was a recent study looking at a variety of groups, sort of ethnic, racial, and political groups. And I think it was under the question, would you definitely not get a vaccine? 14% of African Americans, the Black community, said they would definitely not get a vaccine. But interestingly, when they looked at the political divide, 25% of Republicans said they would definitely, or people identified as being Republicans, said they would definitely not get a vaccine. I mean, somehow we were able to make a virus political. It is remarkable to me. I mean, has this ever happened before? I mean, if you look at major scourges like smallpox, polio, et cetera, I don't think any of those viruses have ever been political. We made this virus political, and it's a shame. It really is a shame, because I think that's what scares me, that there will be a critical percentage of the population that says no vaccine for me, and then we will have a problem, because the only way out of this pandemic is vaccination. That's it.
Right. That being said, I think the encouraging piece is that there are people who were kind of taking more of a wait and see, like, I'm open to getting it, I just don't want to be the first ones. And hopefully, as more and more people get the vaccine and we see, the very few severe side effects, hopefully that builds confidence, and more of those people are able to get over their
I mean, if you look at the polls that were done in October, September, October, December, now, you see a constant increase in people who want to get the vaccine, because just for the reason you said, there's more data on safety. I think that's what people are scared about. I think people believe it works. I just think they want to see more and more people get it and not have something bad happen. And I think we're there now. I think if you were skeptical about this vaccine, it's reasonable to be skeptical. It's a novel technology. It's an unusual virus. It's reasonable to be skeptical. But I think the skepticism should melt away at this point. At this point, if you're still choosing not to get a vaccine, you've moved into the cynical group, which is to say you don't believe the data. You don't think it has anything to do with you. They think that this, that the virus is a hoax, that, you can just avoid it by eating well or whatever.
So, okay, let's think about, as we get to normal, some questions in terms of expanding the pool of people getting the vaccine. What do we know about effects on and potential risks for pregnant women?
Right. So pregnant women were excluded from the trials, the Moderna trial, the Pfizer trial, and the Johnson & Johnson trial. Not surprisingly, when you vaccinate tens of thousands of people, still people get pregnant, which is what happened in about 23 people in the Pfizer trial and 13 people in the Moderna trial. And it was split vaccine to placebo. There were no problems, but this was a very small number. The CDC usually, when you don't study pregnant women should have been studied. I mean, they clearly, if you're pregnant and you're exposed to SARS-CoV-2, you're much more likely to have severe symptoms than if you're a woman of the same age who isn't pregnant. So pregnant women do benefit from this vaccine. So they should have been studied. I think it was a mistake not to. So what the CDC has done, typically when you don't have women that are studied, they say contraindicated, don't get it. We don't have the data, don't get it. They didn't say that here. What they said is that a woman could reasonably choose to get the vaccine because they knew women were at risk, and they couldn't think of a good biological reason for why it would be a problem. That said, science and medicine is humbling, and there are things you find out that you didn't know. So at this point, there's something called the V-Safe system, which is it's based on your iPhone, and the CDC then asks you if you're pregnant, for example, and have gotten the vaccine. They follow you on a weekly basis, and then they will follow your baby up to 6 months of life to make sure there's not a problem with you during your pregnancy and not a problem with your baby, and that there's so far about 30,000 pregnant women have received the vaccine. 16,000 are currently being followed in the V-Safe system. So I think we will know soon enough whether there is any problem. I mean, when people ask me the question, would I recommend that someone get pregnant? I say that it's a perfectly reasonable choice to make.
Yeah. Again. And as we think about, scaling down to kids, you mentioned that the trials in teenagers are ongoing right now. Are there any kids eligible under 16 that are eligible right now, or is that just going to have to, even if they have other potential conditions, or are we just waiting for that first set of trials to come out?
Waiting, the dose ranging trial. So the Pfizer vaccine was approved down to 16 years of age, the Moderna down to 18, and the Johnson & Johnson down to 18. So there's studies done now from the 12 to 18-year-old, which I think will be in hand by early summer. I think that those kids will probably be able to be vaccinated by early summer. And then we'll do studies down to 6 years of age.
Are there any of those trials being done in Philly?
Yeah, Jeff Gerber at the Children's Hospital of Philadelphia is in charge of the pediatric trials at our hospital.
So potentially for those of you in the Philly area, there's an opportunity to ask your kids if they want to contribute and help humanity. So another question that has been on a lot of people's minds is with schools. We've heard in the last week that, at least in Pennsylvania, that teachers are now being prioritized with the J&J vaccine. What other considerations in your mind are important to make sure that schools are safe to return to in-person learning?
Well, first of all, a lot of parochial schools in Philadelphia have returned to, or have continued to have in-class learning. I mean, they're generally wealthier, so it was easier, I think, to mitigate problems by masking, social, physically distancing, not eating together in the cafeteria, not everybody come together on one bus all at the same time. I mean, it was easier to do that. The public schools have less resources or fewer resources, so it was harder for them. But I think that I certainly think we need to get back to school. The on-site learning is certainly better than distance learning, especially for young children. For many children in Philadelphia, as you know, it's the only decent meal they get during the day. Alison Beam, who's the new Secretary of Health, told me that the incidence of child abuse in Philadelphia has dropped to 0, which is to say it hasn't really dropped to 0. I mean, it just tells you that child abuse is often picked up in the school, and then we're not going to school. So there's a lot of reasons to go back to school. And I do think that teachers don't, I agree with Dr. Rochelle Walensky, the head of the CDC, that teachers don't necessarily need to be vaccinated to go back to school. We aren't helpless here. Wear a mask, physically distance, and you dramatically lower your risk of disease. So I think we do need to do everything we can to get back to school. I do.
And the other, lots of questions about, what can we do now that we've had vaccination? We've got some guidance from the CDC this week, but some other questions, particularly around travel. When do we think we'll be able to, go on a plane or travel overseas?
It was surprising to me, actually, the CDC didn't extend the vaccinated person travel advice. In other words, that if you're vaccinated, you can sit on a plane and travel. I think they almost did. They considered it. They didn't do it. I think they were close. We'll see. My feeling about this is that the virus is still out there. I mean, 150,000 cases today, I think is probably what we saw in 1,500 deaths. Hang in there. If you could just hang in there for about 6 to 8 more weeks, I really do think we're there. The weather was warm today. That's a good sign. We're vaccinating 2 to 3 million people a day. That's good. We are going to wear this virus down over this into the summer, and then people are going to feel a lot better. I just hope that we get to that 80% population immunity, because if we don't, it'll be back next winter.
I think that's a really important point to keep coming back to, because humans tend to look at risk in a relative way. And if you had told us last March that the numbers are what they are today, I think we'd all be horrified. But because they were so much worse, we're getting a little impatient. But we still need to kind of hang with it. What about in terms of restaurants? You've been vaccinated. Do you feel comfortable going out to eat yet?
As long as I am eating with someone like my wife, who is also vaccinated, yes. And as long as I am not sitting close to someone else who now is obviously not going to wear a mask because they're eating, as long as I'm 6 feet away, yes, I feel comfortable.
All right. Someday we will go out to eat again. So in our last few minutes here, we have one more follow-up question, actually, before I get to my looking ahead piece. So when we're looking at vaccinating kids, are there different criteria for looking at long-term effects than we necessarily look at in adults?
I think vaccines, like any medical problem, can cause serious and permanent and occasionally fatal effects. That's true. I mean, we just mentioned one, which was the severe so-called anaphylactic reaction. But the oral polio vaccine could cause polio. It was rare, but it occurred in 8 to 10 children every year while we were using that vaccine. We stopped using it in 2000. The influenza vaccine is a rare cause of Guillain-Barré syndrome, which is a neurological disease that sort of starts in your legs, works its way up. It's sort of this ascending paralysis. It occurs in 1 per million people, but it's real. The yellow fever vaccine causes something that has a fancy name of viscerotropic disease, which is just a fancy way of saying yellow fever. I mean, it occurred in about 1 per million people and was occasionally fatal, especially in those over 65. These all occurred within 6 weeks of dose. I mean, narcolepsy, which is a disorder of wakefulness, a permanent disorder of wakefulness, was a consequence of a squalene adjuvanted flu vaccine in Europe. We didn't use that here. Occurred in about 1 in 55,000 people. But all the serious side effects, I had this discussion with people at the CDC and Dr. Fauci. Can you name a serious side effect that is not first evident within 6 weeks of a dose? No. So although those serious side effects can have long-term, it's not like vaccines cause something 10 years later. There is no example of that. So at least not yet. So we'll keep your eyes open, but it hadn't happened yet.
Okay, so now just as we look ahead, a question that we're optimistic about the summer. Could the variants be behind driving another spike before we get to a reasonable level of vaccination? Is there this kind of race going on here between the variants and our vaccination capability?
Yeah, so just to define variants, the virus that circulated in China was not the virus that left China. The virus that left China was the first variant. It had this fancy name, D614G. That's the virus that swept through Europe. That's the virus that swept through the United States. That's the virus that we made vaccines to. All the vaccines we have are to prevent the D614G variant, but now there's other variants. As we talked about earlier, the UK variant, the South African variant, the Brazilian variant. By definition, they're more contagious. The virus is a bat virus. It's a bat coronavirus. It infects bats. Now it's entered the human population. So it wants to adapt to us. It wants to be able to reproduce itself better in us. And it continues to do that. And every time it's made it more contagious. It's certainly true that this vaccine is going to protect easily against the UK variant. So as natural immunity and vaccination will stop that in its tracks. The South African and Brazilian, not quite as well, but at least well enough to keep you out of the hospital. It is a race, I think, with the variants, and that's why it's so important to have full immunity. I mean, you don't want partial immunity. That's how you create variants. Another reason not to get just 1 dose of the mRNA vaccines. And so do I think we can stay ahead of the variants? I do think that. I mean, I hope I'm right. I just heard one of the CNN people today said that he didn't think we were going to, but for all the notion that the UK variant is spreading more, and it is, at least it's more contagious. The fact is that for the most part, the numbers continue to go down. So, and again, vaccine and warm weather works against this virus.
So aside from vaccines and warm weather, I think one of the things that's been really remarkable is to look at the breadth of scientific innovation that has been spurred by this pandemic. Are there things that have come from this pandemic that are going to pave the way out, in the next year, 2 years, aside from the vaccine?
Well, other than sort of the hygienic mitigation strategies, I don't think so. I think that what's exciting about this time, just as a person, an infectious disease person like me, we have entered another era of vaccines. I mean, arguably the 5th era. Angela Desmond at Children's Hospital Philadelphia and I have a piece coming out in the New England Journal of Medicine at the end of this month that goes through that goes through how we have just entered a new era of vaccinology, the genetic era, where you don't give the person the protein, you give them the gene that makes the protein. Right. And I think that could have long-term effects on making a better human immunodeficiency virus vaccine, the virus that causes AIDS, or a better tuberculosis vaccine, or malaria vaccine, or a universal flu vaccine. I mean, will be interesting to see, and it'll have impact on cancer therapy, it'll have impact on gene therapy. I think this mRNA technology is fascinating, and it is a Penn phenomenon. I mean, Drew Weissman and Catalin Carrico are at the heart of that. That paper they published in Molecular Therapeutics in 2008, I think is going to be a Nobel Prize winning paper, but we'll see.
And then finally, as we as we think about this big picture, there, as you mentioned, there are some depressing aspects of this in terms of, we found a way to politicize a virus. But are there more, where do you find more room for optimism in terms of how we might better prepare ahead of time for another pandemic?
Well, if we don't learn from this pandemic, I think we'll never learn. I mean, this virus brought the world to its knees. I mean, this was a crushing virus. I think at the very least, step one is to have an international level of collaboration and cooperation for when these viruses start to spread, that the world is immediately informed of that. That didn't happen here. I mean, we had to depend essentially on a whistleblower in Wuhan to tell us that there was a pneumonia virus that was sweeping across the city. That shouldn't happen. I mean, we should have immediately known that. I think we need to then have much better sequencing resources across the globe. The UK was very good at this. We weren't so good at this. And then we're finding more variants now because we're finally looking, but we need to have much better sequencing characteristics where you sequence the genome of the virus and see whether or not it's drifting. And then, the ability to very quickly produce the kinds of things like personal protective equipment, masking, ventilators. So I think that we have to, as a world, have a plan. I mean, this is just not an American phenomenon. You need, we're only as strong as the weakest country out there. And that's why I like it. I was really upset, actually, when the Trump administration backed away from the WHO collaborative. It was very short-sighted. I mean, you're only as strong as the weakest country out there. So we need to do this as a whole, as a global whole. And we've done that. I mean, we eliminated smallpox from this world. We've eliminated 2 of the 3 serotypes of polio. We can get on top of this virus, but it has to be an international level of collaboration.
Well, on that note, Paul, I think you've given us a roadmap for where we can go as a global society from here, because the risk of pandemics is something that is not going away. But we have so many more tools in our toolkit now to fight them. And we appreciate everything that you're doing on the front lines here in getting these vaccines out to the country, and for all the research and work that you're doing here in Philadelphia. So thank you again for taking the time to join us tonight and give us this valuable update. Thank you to everybody who sent in your questions. We hope we tried to answer as many of them as we could. And again, I can't reiterate as enough how much we appreciate the support that all of you give to the Franklin Institute for the work that we do. We couldn't do it without you. So we'll keep bringing you the news. I hope some of you have a chance to join in my monthly conversations about COVID. I had one yesterday with my daughter, actually, to get a kid's perspective to try and talk about the vaccine to kids. So if you have a young person who is asking questions about the vaccines and when they might get theirs, I encourage you to tune into the program I did with my daughter yesterday. She had a lot of fun. We built little models of the virus out of wiffle balls and Nerf darts and yarn. So that was a lot of fun. So we'll continue to bring you these resources around, how to understand, how to take action around the coronavirus. And please stay safe, and we hope to see you soon. Thank you very much, and have a great evening.